Hi, everyone. Thank you for having me. I'm honored to be here. My name is Nadine Mallak, and I'm a radiologist and nuclear medicine physician at OHSU in Portland, Oregon. The talk today is about what matters about scans for neuroendocrine tumors. And I would like to direct especially newcomers to talks I've given in the past at this meeting, in which I cover comprehensively imaging of neuroendocrine tumors on CT, MRI, and PET scans. Today, I'm going to rather try to address some specific questions that come up frequently. First, this is a topic that I've covered before, but I'm going to reiterate today because it's important. And it's about the multi-phase imaging of the upper abdomen when we're imaging neuroendocrine tumor. So typically CT scans, the standard ones, are done in venous phase. But if we know that we're evaluating neuroendocrine tumors, we want to do it in multi-phase. And the reason for that is that a lot of neuroendocrine tumors enhance on the arterial phase. As you can see in this example of primary ileal neuroendocrine tumor that's metastatic to the liver, we clearly see the metastasis on the arterial phase to the left of the screen, but it's occult on the venous phase. Some other metastases are, however, the other way around. We see them better on the venous phase and not so much on the arterial phase. So if we know we're looking for a neuroendocrine tumor in the liver or in the pancreas, which means in the upper abdomen, we need to get multi-phase CTs. MRIs, on the other hand, are always done multi-phase. But the question that comes up about MRI is which contrast to use. So typically MRI is done with gadolinium, IV contrast, and that's basically what we use if we want to characterize a liver lesion or if we want to image, for example, spine or any other organ. Now, for liver metastases specifically, EUVIST is really good. It is the best contrast agent to basically detect small liver metastases and to reproducibly follow up liver metastases over time. So EUVIST is a liver-specific or hepatobiliary-specific agent. It's taken up by the liver parenchyma and not by metastatic disease. So if we image at delayed time points, so 10, 15, 20 minutes, we could clearly see the metastases as dark holes, as we could see here on the 20 minutes delayed. So to look at this case, on the arterial phase, we see the metastases, but you can see that the measurements are a little bit larger on the arterial phase, and that's because of some blood blush around the tumor. On the 20 minutes delayed EUVIST, we could measure them accurately and reproducibly over time. So EUVIST is our contrast agent of choice if we're following up liver metastases over time. Now let's look at some cases at diagnosis and for staging of neuroendocrine tumors. So this is a patient who presented with an incidental 12 centimeter liver mass on CT. This mass was biopsied, and it was shown to be neuroendocrine tumor, well-differentiated, Ki-67 2%, so it's a grade 1. So dotatate PET was done here to look for site of primary malignancy and to also stage the disease outside the liver. Look at how diffuse the metastatic disease here is. There are more liver metastases than we knew of, and there are a lot of bone metastatic disease. And here, the dotatate PET shows clearly the site of primary neuroendocrine tumor, which is in the distal ileum, and I'm pointing to that with a yellow arrow. In addition, you see at the bone metastases, which are diffuse, and we see them very well on PET, are actually occult on CT. So if you look at this red arrow pointing to a metastasis in the right iliac bone, we do not see it on CT, but we see it clearly on PET. So dotatate PET here allows us to detect the primary and to stage the disease. Now, if you look back at the CT, we kind of look in retrospect, we kind of see that this tumor was there on CT, but it was really difficult to see. Knowing it's there and looking back, we could actually see a little bit of enhancement there. But detecting that prospectively, it's hard on CT. Now, luckily, things are not as dramatic all the time. So this is another small bowel primary neuroendocrine tumor, and it's pointed out with the yellow arrow. And here, the dotatate PET helps us stage the disease. And this is kind of a classic site of metastatic disease from small bowel neuroendocrine tumors, where they go to the mesentery and to the peritoneum often. So this case had metastatic disease to the mesentery. Now, this is another case. This is a case of pancreatic neuroendocrine tumor. In this case, it was also detected incidentally, where we see on CT that was done for other reasons that there is a mass in the head of the pancreas, the blue arrow, and there is a liver metastasis, the red arrow. So the liver metastasis was biopsied and it's shown to be neuroendocrine tumor grade 2. So dotatate PET here done for staging. Here we see the pancreatic mass, the liver metastasis, and also a lymph node in the upper abdomen, the yellow arrow. So the metastatic disease pattern is different for pancreatic neuroendocrine tumors. Those don't go to the mesentery and peritoneum as much, and they spread to lymph nodes around the pancreas and to the liver first. Now let's talk a little bit about the implication of uptake or the SUVs or somatostatin receptors. So somatostatin receptor density, the higher the somatostatin receptor density is, the higher the uptake is going to be on dotatate PET. So sometimes questions come up as like, how can you tell that there is somatostatin receptor expression? And the clinically meaningful question is actually, how do we tell that there is enough somatostatin receptor expression? Because there might be some expression, but it's not clinically meaningful, which means that the disease we're not going to be able to stage it accurately with dotatate PET or treat it with PRRT. So sufficient somatostatin receptor expression is going to translate as uptake higher than background liver on dotatate PET. So it's not an absolute SUV number. It is basically higher than background liver. So it's an internal reference to the liver parenchyma. So if the uptake is lower than that, it means that it's not sufficient expression. Dotatate PET is not going to be good in these cases to stage the disease, and PRRT would not be a good treatment option. So in this case, we see very intense expression. So this is definitely somatostatin receptor positive disease by dotatate PET. Let's compare that to our next case, and here a metastatic lung NET. And although the Ki-67 is 4%, lower than the case before, there are a lot of liver metastases that we see clearly on MRI, and they're not showing uptake higher than liver parenchyma on dotatate PET. And there's a lot of bone disease, and that's also showing uptake predominantly less than background liver. So this is not enough somatostatin receptor expression. Even if there's a little bit, it's not clinically meaningful. Now let's go to surveillance and post-treatment evaluation. So for surveillance, especially if we see the disease well on CT and MRI, we use that for follow-up. We could get dotatate PET every once in a while just to make sure that there is no disease outside the abdomen and pelvis that we're not seeing well on CT and MRI. Now, if the disease is mostly occult on CT, and that's basically if we have a lot of bone disease, for example, that's difficult to see on CT, then we need more frequent dotatate PET to follow it. For response to treatment, we use the size on CT and MRI, but also the morphology, as I'm going to talk about in a bit. And we use dotatate PET after treatment, which is going to be a new baseline for the future. It's going to allow us to detect earlier if there is unequivocal progression after treatment. And we assess for response on dotatate PET by either disappearance of known lesions, development of new lesions, and very important point is that the changes in SUVs alone do not indicate response or progression. So I'm going to show you a few cases of follow-up post-treatment. RECIST 1.1 is what we use on CT or MRI, where we actually follow the size of the lesion. And here, if you look at the criteria, we measure target lesions, and we take the longest diameter of these target lesions, we add them up, and we follow the sum of the diameter. We need a change of more than 30% reduction to call that response, and more than 20% increase to call it progression. And the reason for that is sometimes you can have a little bit of variability, like first in between people, like if you have two different physicians measuring, you could have like a little bit of variability of few millimeters. So that's not clinically meaningful. And also if you have different modalities, let's say CT the first time, MRI the next time, you might have like a little bit of variability. So to make sure that it's clinically meaningful, these thresholds of 30 and 20% have been set. Now, the RECIST, although it correlates with outcomes and is the most studied in clinical trials, it has limitations. It does not account for the texture of the tumor, how heterogeneous it is, if necrosis happens over time, and the slow growth of the tumor also, like sometimes you need a long time to reach these 30 and 20% changes. So some other criteria have been proposed. They still need to be studied in clinical trials, so we don't use them clinically, but they have been proposed, so I wanted to mention them. For example, the CHOI criteria, for which they look for a smaller change of 10%, which takes into account slow growth and also change in density. So if we have less enhancement, more necrosis, that's also a feature of response to treatment, even if the size doesn't change much. So pseudoprogression is also another kind of limitation for the RECIST criteria and the size only to assess for response, but we see it only early on after treatment. So if we continue follow-up, that pseudoprogression is going to reveal itself that it's only pseudoprogression. And that's basically necrosis and edema in the tumor right after treatment might cause the size to increase a little bit before it starts shrinking. So it's something to be aware of and to wait for, basically, as we follow up after treatment. So to show you some examples, this is a nice example of response to treatment after 2 cycles of PRRT. We see liver metastases, they decrease in size after treatment, so that's great. Now here's another example, and this is after chemoembolization. And after embolization, we see more frequently the change in enhancement in the tumor. So here the enhancing tumor pre-treatment is not enhancing afterwards. So that's what we call necrosis. So the tumor is dead. And we see that just from the change in density, not only the change in size. So the size is shrunk a little, but also the features here tell us that this is a good response. Now, this is another similar case where actually after treatment, we see necrosis and lack of enhancement in these tumors, and then they continue to shrink over time. So on dotatate PET, we look for resolution of lesions that were seen before or appearance of new lesions on dotatate PET to tell whether there is response or progression. So in this case, post-PRRT here, I'm pointing with blue arrows to some metastases that resolved afterwards. So this is a good sign of response to treatment. Now let's look at some of the mesenteric and liver metastases. So this is a mesenteric mass. The size is the same on CT. The SUV went up. So this is an example of changes in SUV alone do not indicate response or progression. So although the uptake kind of went up, we're looking at receptor density. So it doesn't really signify that there's progression. Here, like the mass is stable, some of the lesions disappeared on the post-treatment PET, and the liver metastases are stable on CT. So this is a good response to PRRT, and we continue following up. Now, some of the questions are basically, what are red flags on CTs or MRIs? What do we need to worry about? And there are 2 things mainly. First, if we have rapid growth of tumor. So if we have a well-differentiated neuroendocrine tumor that's growing slowly, if it starts all of a sudden growing at a quicker pace, that's concerning. And if we see any tumor that is not showing uptake on dotatate PET. So I've shown in past talks some tumors that were not showing up on dotatate PET and how we manage those. Now, this is another case in which here we have a pancreatic neuroendocrine tumor. It's a grade 2. This has been treated with debulking first and then with CAPTEM. And now the patient has been on surveillance. And then we see all of a sudden within the period of 3 months, the tumor started growing quicker. So here we have a change in size of about 40% of this liver metastasis. In these cases, we worry about higher grade disease. We could either do FDG PET or biopsy. In this case, we did FDG PET, and we see that the tumor is very hypermetabolic. So that's basically a sign of higher grade disease. This was taken out. So this couple of tumors in the right liver lobe were resected, and the Ki-67 here was higher. So it was grade 3, and it was more aggressive than the initial tumor a few years ago. So the take-home messages from this talk: the best follow-up modality and the best surveillance is going to depend on tumor location. The response assessment and follow-up is going to basically be based on tumor size and morphology, on CT and MRI, and on dotatate PET, with the important point that changes in SUV alone on dotatate PET do not indicate response or progression. And signs that we worry about is if we do not see uptake on dotatate PET, or if we have rapid increase in size of the tumor, and then we could do FDG PET or we biopsy to look for higher grade disease. Thank you very much, and looking forward to your questions.